Welcome to the Fitzhugh-Mullen Institute for Health Workforce Equity mini-series, examining health workforce policies during the COVID-19 pandemic. My name is Julia Strasser, and I'm a senior research scientist in the Mullen Institute. This webinar will explore the unique challenges facing the abortion provider workforce during the COVID-19 crisis and policies that could be implemented to address these challenges. Although abortion is a medical service, it is often treated differently from other procedures or types of care because of political or other non-medical considerations. Some states have designated abortion as an elective procedure and have required all abortions to be postponed unless the life of the pregnant person is threatened. Other states have designated it as an essential service that can continue to be provided. As these policies differ by state, abortion providers may be struggling to understand what they're permitted to do, as well as having to rapidly change their practices for abortion service provision to account for risks associated with exposure to COVID-19. To talk about these issues in more detail, we have three panelists joining us today. Dr. Alice Mark is the Medical Director for the National Abortion Federation, a membership organization of abortion providers and facilities in the United States, Canada, Colombia, and Mexico. Dr. Mark is an OBGYN who completed residency at Brigham and Women's MGH and a fellowship in family planning at Boston Medical Center. She is an abortion provider at Planned Parenthood League of Massachusetts. We also have Heather Shumaker, a senior counsel for Reproductive Rights and Health at the National Women's Law Center, where she works to advance state laws and policies that protect reproductive rights and promote access to comprehensive health care. Prior to joining the center, Heather was State Policy Director at the National Abortion Federation and the Senior Public Affairs Director for Planned Parenthood Keystone. We also have with us Dr. Jen Villavicencio, who is a Cuban-American OBGYN and abortion caregiver in Michigan and is a clinical lecturer in the Department of Obstetrics and Gynecology at the University of Michigan. She will complete her master's in public policy there this month. She is passionate about compassionate clinical caregiving, messaging around abortion for social change, and reproductive justice-based health policy. Dr. Mark, I'll start with you. Can you tell us a little bit about how abortion providers have changed their practices to respond to the COVID-19 crisis and how the crisis has affected the abortion workforce capacity?
Well, thanks so much, Julia, and thanks so much to the Institute for having me here today. So I am going to talk to you just a little bit today about sort of abortion as it's delivered before the COVID crisis happened, how it's shifting on the clinical side, and then talk a little bit about some of the workforce issues that are happening because of COVID-19, and really workforce issues that have been longstanding in abortion care that are being highlighted now that there's this current crisis. So what happens now in face of COVID-19? Every healthcare service has been modified to really think about how can we shift service so that there's less patient-patient interaction, so patients aren't sitting together breathing on each other in a waiting room, and that there's less patient and staff interaction, and still maintain essential services, of which abortion is certainly one. And it turns out that there's been a tremendous amount of research and evidence that's been generated over the last years that have really contributed to being able to modify abortion services to make them have less face-to-face interaction between a patient and a staff member. And really medication abortion has been a focus of that, but that's true for all areas of abortion, including procedural or aspiration abortion. So one thing that's really been so positive has been using telehealth technology to provide abortion. So providing most of the abortion service either over the phone or using video technology is something that has been rapidly picked up over the last few years by many, many clinics. Reducing testing before abortion. So when medication abortion first started, patients did have to have quite a bit of lab testing, blood testing, ultrasounds before an abortion. I think, again, just not knowing whether it was okay to sort of provide abortion safely without all that testing. Well, it turns out when you do the research, most patients need almost no testing at all before an abortion. They really don't need blood testing. And many patients who know their last menstrual period or know the date that they got pregnant, they don't even have to have an ultrasound. So when you reduce that testing or when you reduce ultrasounds, that's less contact between patient and staff. Medication abortion used to be a visit. It took 3 clinic visits for a patient to get through a medication abortion, and now it's basically down to 1 because a patient still has to go and, for the most part, pick up pills in a clinic. But we know that a person can understand whether that abortion has been successful on her own by using like a phone follow-up checklist and a home pregnancy test that she might buy in a pharmacy. So using remote follow-up for medication abortion is one thing that if a lot of clinics were not doing it before this, they are definitely transitioning to that now. And then looking at flow and staffing within a clinic, we definitely talk with our providers about how can they, for example, instead of a patient moving from room to room to have counseling here, labs done here, get their weight checked here, go to the procedure room here, how can a patient go into a clinic, go directly to a procedure room, have people come to her, and then reduce the amount of time that there's interaction. So we've talked a lot about how can you change a practice to accommodate patients safely, do the procedures that you want to do, but decrease staff. All of these things are evidence-based. They all are incredibly safe, and they are all actually things that increase patient satisfaction. Patients like it when they don't have to come to the clinic for a return visit. However, there's a limited ability to change, to really take these things on because of the excessive regulation around abortion. I'm sure Heather is going to get into that next, so I won't go into it here, but abortion is the most regulated procedure, and there have been specific regulations around many of these things that people want to do. So for example, states, especially maybe rural states, will have a lot of leniency around telehealth for other medical encounters, but will specifically say no telehealth specifically for abortion. So that cuts off an option there. Some states will say a patient has to have XYZ laboratory testing, even though there's absolutely no evidence before they have an abortion. So those are some regulatory issues that make it very difficult for some of our clinics to change their practice. Next slide, please. So what about the landscape of abortion in the workforce? Well, already regulations have closed clinics across the country. So because of the regulatory environment, clinics are faced with targeted regulations that are put forth in the name of patient health, but are truly just meant to make it impossible or difficult for clinics to keep their doors open. So already there are so many patients across the country who have to do a tremendous amount of seeking, driving, coordinating to find an abortion provider that's even open. So there's already an environment that we're working in where there's very, very limited access to abortion providers for many, many people around the country. So the whole community was actually anticipating tremendous changes in abortion access this summer if there was not a positive Supreme Court decision from the Louisiana court case. That decision has not even come out yet, and here we are already facing this incredible challenge with clinic closure and clinics having to modify the care that they're giving. Some states, because of the previous regulations that were in place, are already down to one provider. So North Dakota, South Dakota, West Virginia, Missouri, Kentucky, Arkansas, and Mississippi all have one remaining provider in those states. So functionally, access in those states is already incredibly restricted. And then abortion, especially for independent clinics. So I'm talking about clinics that are not necessarily Planned Parenthoods, but smaller clinics that might be run by a clinician or an owner who just wants to continue to provide abortion care. Abortion is a very low margin procedure. It is a procedure where cost is incredibly prohibitive to patients. So providers keep their costs very low to ensure access. But what that means is that many clinics are really working on a shoestring. And so you have a crisis like this that might temporarily change how many patients you can see because you're trying to slow down patient-patient or patient-staff interaction, or keeping patients out of the clinic because they're afraid, or even they have to close their doors because of regulations or because of staffing issues. The lack of margins within the abortion clinic means that it is extremely difficult for those clinics to weather those storms. And we saw that actually in Texas when HB2 closed clinics. Many of those clinics were not able to reopen even though they had a positive Supreme Court decision. A lot of clinics in especially hostile states where many abortion providers don't necessarily want to live or work, they often depend on traveling providers. So COVID-19 has specifically been hugely impactful for them because they might have an older physician who is worried about their own risk in traveling, so they decide not to travel, or there's travel restrictions in place. With a 70% reduction in the amount of air travel that's happening right now, it's extremely difficult for a provider to get into a clinic that might need them to come to be able to open. So travel restrictions are tremendously difficult in this time. And then finally, clinics depend on part-time and low-wage workers who have other responsibilities. So clinics really depend on their staff to be able to come in, but in the face of a crisis like this, staff might be sick themselves, need to take care of sick family members, have childcare things that they need to do, or themselves are afraid of coming into an environment where they might have a lot of close contact. So again, the landscape was fragile before, but COVID has really exposed so much of that fragility. Next slide, please. So what are some of the barriers that really could be taken down and helpful? Well, most of them are regulatory. So excessive regulation is something that has always been a challenge for abortion clinics and is even more challenging now. That coupled with the state's desire to close clinics and using the pandemic as a completely mercenary opportunity to end abortion in their own state. So, you know, Texas does not have to go through this, the legislative process, and they don't need to go through the judicial process. Instead, they've used this emergency process to achieve a goal that they wanted to achieve for a very long time. Whether that is legal or not is something that I'm sure Heather's going to talk to us about, and what's being done to prevent that is something that's on Heather's plate. But that has been incredibly critical if you think of the number of patients who one day had access in Texas and maybe they had appointments ready and set to go, and the next day they are out of luck and they need to find another provider, often in a state next door to them like Louisiana that's incredibly fragile. The second barrier is the FDA REMS agreement. So this is a little bit more complex, but mifepristone which is the first medication abortion, is highly regulated. And one of those regulations is that mifepristone cannot be picked up in a pharmacy. It cannot be mailed through the mail. Instead, a patient must actually go in person to a clinic, and the clinic is the person who distributes, the provider themselves, actually, not the clinic. So the provider, the physician in most states, and luckily in some states, the advanced practice clinician, has to actually hand the pill to the patient. There is no evidence to support that that protects patient health or is useful in any way. However, that FDA REMS stands so that patients, even if they can get all their other care outside the clinic, consent, maybe they can get their follow-up outside the clinic, they still have to show up in the clinic to pick up those pills. When we know that, through evidence and through other countries, we know that they can just as safely and easily, actually much more safely, go to a pharmacy or have those pills put in the mail. Practice restrictions are a huge barrier. So in many countries, in many states, only physicians can provide abortion care, which of course limits the provider pool. In states where advanced practice clinicians can provide abortion care, that obviously expands the provider pool so that more people have access. And then for all healthcare, state-based licensing is a huge barrier. So if you have a clinician who's licensed in the state of Florida, but they need providers in Louisiana, it's an incredibly onerous process to try and get those clinicians from state to state. And then the final thing that's a huge barrier is perception. So there's a huge perception out there that abortion is rare. I mean, who has one? Does anyone? We know that's not true, but people don't talk about abortion, and that's absolutely fine. It's a private decision that they make, and some people talk about it and some people don't. There's a perception that it is dangerous, which is completely untrue. The opposite is true. It is safer to have an abortion than it is to continue a pregnancy. And there's a perception that abortion is regrettable, and that is also completely untrue. So those perceptions lead to the fact that perhaps abortion needs to be regulated by those who might know better than the person who's making the choice to have the abortion herself. So I think the reality is that abortion is common, it's healthy, it's normal, and it should be easy to access without restrictions or shame. Now, that was all true before COVID, but with COVID in place and with the fragility of the current abortion landscape, it's even more important for people to understand how essential that healthcare is, how positive that healthcare is, how safe it is, and how it actually improves lives and reduces impact on the health system rather than the opposite. Next slide. So that is what I have for you today, and I'm really looking forward to hearing from my colleagues about other aspects of abortion care during COVID.
Thank you, Dr. Mark. That provides us some great insight into some of the particular barriers and challenges that providers are facing, especially right now. I'm going to turn it over now to Heather Shumaker. Can you give us an overview of the policy environment, especially at the state level, that's affecting abortion providers right now?
Hi, everyone. Yes, happy to do so, and thank you for having me on the webinar. I also wanted to take the opportunity to say thank you to all the healthcare workers that are risking their own health to protect ours during this time, and a special thank you to the abortion providers that have always risked their safety to provide healthcare. They're on the front lines today too, and they don't get enough thank yous. So I'm going to be talking about the ways that during the current public health crisis, abortion has been classified as non-essential or essential via state executive orders, and give it a couple examples of how states have done that, and then also talk about the resulting legal challenges, as we often do in the abortion rights world. So I'm going to start by acknowledging what I think all of the folks that are listening today already know. From a values perspective, abortion is certainly always essential healthcare, and particularly during a public health crisis and a time of uncertainty, it's more than ever an essential healthcare service. So at the same time, we of course know that abortion has been politicized in our country, and that abortion opponents will go to great lengths, even unconstitutional ones, to prevent people from accessing the care that they need. Dr. Marks alluded to this, but even before this crisis, there were already a number of laws in place, over 400 passed since 2010, that restrict access to abortion. And those laws create barriers that fall most heavily on marginalized communities, including people who have low incomes, people of color, young people, LGBTQ people, and people that live in rural areas. And now the pandemic is really exacerbating those barriers to abortion that already existed. That travel and public transportation restrictions under the pandemic, limited childcare with childcare facilities closing, and job insecurity and economic stress put abortion out of reach for many people. And then on top of that, existing medically unnecessary state abortion restrictions also put abortion providers, patients, clinic staff at increased risk of exposure to COVID. So for example, some of the laws that require multiple medically unnecessary trips to a clinic, or medically unnecessary ultrasounds or follow-up visits in person, they all increase contact at a time when we know we're supposed to be social distancing. And Dr. Marks mentioned a couple of those as ways that in states where providers are able to do so, they're actually shifting the provision of care, which makes it all the more burdensome in the states that aren't able to do that. And then there are other laws in place, like funding restrictions, that just make a tough financial time even worse for folks that are seeking abortion. So while these barriers are all pushing patients later into pregnancy and closer to the legal limit in their state, abortion opponents are unbelievably at the same time exploiting this crisis to make abortion even more inaccessible. So I'm going to focus on state actions, but I did want to mention that it's kind of happening on all fronts. It's not just happening at the state level. We've seen at the federal level attacks on abortion in all of the federal relief bills in places where you would be shocked to know that they're attempting to make abortion accessible. And we've also seen anti-abortion protesters using this as an opportunity to ramp up their protests and harass and intimidate patients and providers, and totally disregarding stay-at-home orders and social distancing norms. So switching gears to the states where there is also quite a bit of activity, just as an overview, most states, I believe the exceptions are North Dakota and Wyoming, have some type of order in place. That includes DC as well. And so most states have some type of stay-at-home or shelter-in-place order. And most other states also have some version of an elective procedures order in place that says that healthcare providers should stop or postpone procedures that are non-essential, that are considered elective during the crisis. So that's where things get a little bit more confusing for abortion access, because the orders aren't necessarily explicit on what procedures are elective or essential. Very few make explicit what procedures are elective or essential, including abortion, but most don't. And the language that discusses what is elective or essential is necessarily even in the order itself. from the state. In some states, there isn't even additional public guidance, which means that it's up to the discretion of medical providers. So I'll give a couple examples. And also I did want to mention that medical groups have weighed in as well, and this is largely in reaction to what the states have done. As an example, the AMA, the American Medical Association, has really leaned into the fact that it should be their physicians, not politicians, deciding whether a procedure is urgent or emergent and whether it needs to be performed, whether it can wait. A joint statement of medical groups, including ACOG, has said that to the extent that facilities are categorizing procedures that can be delayed during the pandemic, that abortion should not be categorized as such a procedure. So major medical groups are in agreement here with reproductive rights advocates. So a couple specific examples of what the states are doing. One example of a state where it's not clear what is essential or elective and there has been no further guidance, leaving it up to the medical providers, at least with respect to abortion, is Maryland. So that order says that all licensed hospitals, ambulatory surgical centers, and other licensed healthcare facilities shall cease all elective and non-urgent medical procedures. And it further says that healthcare providers shall perform only medical procedures that are critically necessary for the maintenance of health for a patient. It all sounds well and good. It leaves it up to the medical providers to determine what those things are. And this is what a lot of states' executive orders look like. And, you know, it's fine in a place like Maryland, which is generally has accessibility to abortion, but we're certainly watching similar orders in other states where the states have been more hostile to abortion access to see what's going to happen there. Another example of a state where things are good, where the order is a little bit more explicit, is Washington. So their governor issued an order on restrictions on non-urgent medical procedures, and specifically said that certain things are prohibited, specifically things that can be delayed and are not anticipated to cause harm if it's delayed for at least the next 3 months. But in that order, the governor specifically said that that prohibition does not apply to the full suite of family planning services, which advocates have interpreted to include abortion. And then an example where a state, where the order itself isn't explicit, but then there has been some guidance from a state official that makes clear that abortion can continue, is Massachusetts. So the initial public health commissioner ordered the postponement of non-essential elective invasive procedures, but then a couple days later, the Department of Public Health issued a guidance memo that clarified that terminating a pregnancy is not considered a non-essential elective invasive procedure for the purpose of this guidance. So those are some of the positive examples. Shifting to many of the other states that I think have been a lot more in the news and that folks have been hearing about, some of the hostile states. So I couldn't find any examples of states where the order itself has been specifically says that abortion is elective or non-essential. I think that that's purposeful because it's a lot easier for lawyers to attack. And instead, rather, the orders tend to say something more vague, like I mentioned before, like medical providers have to postpone all elective surgeries, minor medical procedures until X date. And then there will be some sort of statement that makes clear that state officials believe that abortion is elective or not essential. So a perfect example of that is Texas. Towards the end of March, the governor issued an executive order prohibiting all surgeries and procedures that are not immediately medically necessary. Then, of course, we heard from the Texas Attorney General that he interpreted the executive order to classify abortion care as a non-essential healthcare procedure, and threatened that any type of abortion that isn't medically necessary to preserve the life or health of the mother, his words, is a violation of the order and threatened legal action. In his words, will be met with the full force of the law. So those are the types of orders that we're seeing litigation popping up. So litigation in Texas, Alabama, Iowa, Ohio, and Oklahoma is ongoing. Those states' attorneys have asked for temporary restraining orders to stop anti-abortion politicians from blocking access to abortion. And in a number of states, temporary restraining orders have been granted. Texas, Ohio, Alabama, and Oklahoma, which means that at the point when those temporary restraining orders were granted, abortion providers could resume offering abortion. Unfortunately, as you probably heard, that's not where the story ends in a lot of the states. Appeals were filed by the state in Texas, Ohio, and Alabama. The good news in Ohio is that appeal was denied and their temporary restraining order remains in effect, at least for now. The negative one, and I shouldn't have ended on a negative point, but Texas appealed their temporary restraining order to the Fifth Circuit. And initially, we got bad news that the Fifth Circuit issued a stay, which meant that providers couldn't provide abortions until the Fifth Circuit made a final decision. But then more recently, we got word that the Fifth Circuit was going to uphold the Texas order. So basically, abortion is blocked in Texas until further notice. And I think that there were rumblings that they could be appealing to the Supreme Court, but we don't really know right now. So I think that's, ending on a bad note, I guess, but a perfect example of how those who are opposed to abortion are really just exploiting this public health crisis to further their agenda against abortion.
Thank you so much. That's a great summary of the various and complicated policies that are going on across these many states. I'm going to turn now to Dr. Jen Villavicencio. Jen, if you could talk a little bit about what's going on in Michigan in particular and how providers are responding in your area to the crisis.
Absolutely. Thank you so much for having me. As has been discussed, COVID-19 has turned clinical caregiving on its head, particularly in abortion care, and it's definitely presented some very interesting health policy challenges. I am going to use the state of Michigan, where I practice, as a case study to examine some of the issues that have been discussed during this webinar already. So we can go to the next slide. As you may know, Michigan does rank among some of the top hardest hit states in the COVID-19 pandemic. And as you can see from this map, the vast majority of our cases are concentrated in Southeast Michigan, with the Detroit metro area bearing the brunt of that. This has raised significant concerns and spurred conversations about racial, ethnic, and socioeconomic disparities and how COVID-19 is impacting communities, as well as the underlying health systems that contribute to these disparities. These unacceptable health disparities are amplified in abortion care, where access has been limited prior to COVID as well as now during COVID. And therefore it's more difficult to obtain, which leaves people of color, immigrants, LGBTQ, and people with lower incomes at a higher risk of being unable to get the healthcare they need. On the next slide, we can see a map of Michigan. These are two Google Maps that I actually searched for today. The relevant search terms are Planned Parenthood and for abortion. I'm presenting these maps to demonstrate what a patient may see on any given day when they search for services. And as you can see, the available clinics are concentrated primarily in Southeast Michigan, which, as I just mentioned, is hardest hit with the coronavirus. And of note, many of these clinics have reduced their hours or temporarily closed altogether due to the strain from the pandemic. So pairing this with the existing abortion restrictions that exist in the politically hostile environment that is Michigan, abortion access has really been threatened due to COVID-19. So on the next slide, having that context in mind, we have had a lot of challenges, but it's not as bad as it could be. We're fortunate here in Michigan that we have a supportive governor, a Democratic governor, who acted swiftly with executive orders for both the shelter in place as well as guidance to the medical community about elective procedures. And here you can see the full text of those orders for reference in comparison to other states. On the next slide, you can see a zoomed in aspect where she specifically carved out pregnancy-related visits and procedures, which includes abortion care. We're very thankful to not be facing a ban or a moratorium like in Texas, Ohio, Iowa, and the other states that have been mentioned. It does, however, bear repeating that abortion is by its very nature an urgent medical procedure because it is time constrained. It becomes inaccessible if it's delayed too long. And so I, as an abortion provider, feel exceedingly fortunate to be in a state where I'm not facing jail time for providing necessary and urgent healthcare to my patients. what we have seen on the next slide, unfortunately, is that protesters at our clinics are ignoring our stay-at-home orders. They continue to gather outside our clinics and put our safety and the safety of providers and patients at risk. They have also gone so far as to sue our governor for violation of their right to free speech. And this is quite interesting from a policy and legal perspective when put in the context of anti-choice groups celebrating the banning of abortions in several states and the recent Fifth Circuit decision that was mentioned by Heather to allow the Texas ban to stand. It seems like anti-choice groups are really interested only in some constitutional rights being protected during the pandemic and not others. Excuse me, on the next slide. It's been challenging to work as a full scope OBGYN and balance the needs to show up for the pandemic, but also continue to provide the needed services like abortion. Because abortion, unfortunately, has become siloed in outpatient clinics, I work in both a hospital as well as in outpatient clinics. And so for myself and many of my colleagues, we've been asked by our institutions to be ready to deploy outside of our specialty, potentially to newly built field hospitals and COVID wards and ICUs. This has put a strain on our schedules and our ability to show up for our patients in the abortion clinics, as well as making sure that we're taking care of patients who also need it from a COVID perspective. We're worried about the availability of personal protective equipment as well, and how to ensure that we cover all of the essential services. You can put the next slide. We have collaborated also as a group using our collective knowledge and dedication to family planning to ensure that we're being good stewards of those resources that I just mentioned, because PPE is on a national shortage. We want to make sure that we're protecting patients and staff and also continuing to provide all of our services. So as was mentioned by Dr. Mark, we've increased medication abortion, which requires much less face-to-face interaction, as well as counseling patients that they can delay their LARC placement, either if they already have one in place, when they already have one in place, excuse me, based on the evidence of extended lifetimes. So for example, I've called a lot of my patients and talked to them. They originally maybe wanted a surgical procedure or an aspiration abortion, and I've talked to them about the equivalent safety of medication abortion and that they would have less interaction with need less interaction with our staff. And most patients are very amenable to that because they also are worried about their safety and worried about being able to access those services. Additionally, I've had patients that have reached the 4 or 5 year mark on their Mirena IUD, for example, which is FDA approved for 5 years, but we know from great scientific evidence lasts up to 7 years. And so we've told them, hey, do you want to push out your appointment to replace that IUD for a couple of months so that you don't have to come in during the pandemic? And patients have been very amenable to that as well. So we're trying to do our best to determine exactly what is essential in family planning while being good stewards of our resources. We here in Michigan do remain committed to ensuring that whoever needs an abortion can get one done. And again, I want to reiterate that I'm very fortunate to be both in the state as well as an institution who's allowing that to happen. And finally, on the last slide, I just wanted to make another shout out to the professional organizations that have been backing us up. There's been amazing collaboration with the American College of Obstetricians and Gynecologists, also known as ACOG, and all of the other organizations here you can see at the top there are professional society organizations that have made sure that abortion remains an essential service. And that down at the bottom is a list of advocacy organizations that have also put out those statements. And these statements have been used both at the institutional, local, and state policy making levels to influence how care is provided during these uncertain times. And without these collaborations and without these statements, we likely would be in a very, very different place in Michigan. So thank you very much for having me, and I really appreciated kind of using Michigan as a case study.
Thank you, and thanks for sharing your experience. So I would like to ask a few follow-up questions to clarify and get some more information about some of the things that you guys have mentioned. So first, Dr. Mark, you mentioned that there are some changes that have been made and can be made to clinic flow to reduce the risks to staff and providers. And I was hoping you could give us an example or two of some of those changes that could be made.
Sure. So, you know, when this first happened, we definitely talked a lot about how to structure a clinic visit to make sure that the risk is really minimized of COVID transmission. And so most clinics now have set up screening procedures where patients are pre-screened on the phone before their appointment and then screened, at the door or by a security guard for signs or symptoms of COVID. We have clinics who are trying to space out appointments so that they don't end up with a full waiting room, but rather have patients, be more staggered. So, at some abortion clinics, just because it's, fundamentally, honestly, it's a lot easier. They bring all their patients in at one time, sort of do counseling, do labs, and then push people through, and then sort of they wait and have a procedure. But encouraging people to really do more like one patient comes in, counseling labs procedure, and spread things out over the day. For medication abortion, again, that's a huge opportunity to reduce in-person contact. So we've even had clinics who will do all the consenting on the phone. Patient comes in, there's already a little baggie of medications and stuff prepared for the patient, and then the clinician will run to the car, give them the bag of medicine, sign the consent form, see you later. So even trying to figure out like how can you, to the best of your ability, minimize the contact that absolutely has to be done during a medication abortion procedure, which is for the most part, for patients who know when they got pregnant, handing over the pills. So those types of changes. And then the thing we are asking people to try and understand is, what is essential staffing when you're doing an abortion? So again, there's some regulatory issues there that says, if you're doing IV sedation, you might need to have this type of registered personnel with one of these types of registered personnel, or, do you actually need the number of personnel that you have? And can you think of ways to streamline your personnel? Unfortunately, we have had to do things like say that people, unless they absolutely must, shouldn't be having escorts or accompaniment in the building, which is obviously is tough on patients. They want to have their family or their loved ones there with them when they're going through a medical procedure. So those are some of the examples that we've used. Jen, I'm sure you've probably heard or thought of many more.
Yeah, I think all the things that you mentioned are things we're doing here. One of the other things that I know we've ramped up is telemedicine abortion. And we were able to overturn the ban that we had on telemedicine abortion in Michigan in December 2018. And so it's a fairly new process for us, but we have really sort of quickly deployed it across all of our health centers to be able to continue to do that in a faster manner than we originally planned. And so that's been really, really helpful. And I think encouraging patients to consider medication abortion versus surgical abortion and the reasons for that in the way to protect the patients as well as the staff, and not telling anyone that they must have one or the other, but really thinking about it in the context of exposure rather than purely preference. And that's been a really tough thing for us to do, but has been a necessary thing for us to do.
Yeah, and I want to add to Jen's statement about telemedicine. Health and Human Services has put out a statement that has allowed a lot of clinicians, not just abortion providers, to use FaceTime, Zoom, Google Hangouts for face-to-face video contact with their patients. And that's something that we were definitely encouraging providers to take them up on that offer. So even in states that are less hospitable to telehealth for abortion, which part of the procedure is the abortion? So are there things that you can do over the phone that you might have done in clinic, even collecting a health history, having a patient do forms? So, telehealth is it's a bit of a loaded term because I think it implies a lot about the health interaction. But if you said, okay, what of all the things that you do when a patient hits the clinic could you potentially be doing when the patient is sitting in the car outside the clinic or is even in her own home? What are those things that you can do? Then it sort of gets away from telehealth and gets you really into thinking creatively about how to restructure a clinic visit.
And just to sort of follow up on that, as these changes are being put into place, they're happening very rapidly, and obviously providers and staffs are having to kind of think on the fly, make these decisions quickly. What would you say is I guess either are some challenges that providers are facing with keeping up with those, or what are some of the best ways that providers have been able to kind of stay on top of these as they're sort of navigating these complex issues?
So
go ahead.
That's a question anyone can answer that.
I think for better or for worse, abortion providers and all of the staff that work in abortion health centers that provide abortion are really very skilled in being innovative and in figuring out how to provide care, because we are constantly, especially those of us who live in hostile states, constantly being threatened or having new rules come down that maybe don't make any sense. And so for better or for worse, I think we're actually in a really great position to be able to think outside of the box in order to make sure that our patient gets care, because that's what we do all of the time.
Yeah, I would definitely agree with that. And then the other thing about abortion providers is that we all know each other. So we do spend a lot of time, whether it's through the Fellowship in Family Planning, which is sort of an academic group, or a group like NAF that has a provider base. There are other provider groups, Abortion Care Network, that we talk. So, if somebody hears that this clinic has a really unique way of doing things, then that message gets out. So one of the things that I think has happened right now is the community really coming together to sort of make changes that I think a lot of people had wanted to make for a long time, but finally getting the push, unfortunately in a crisis, but fortunately getting pushed to consider, can you do a medication abortion with no labs in front of it? Here's your opportunity. So we've watched different medical groups, medical directors, organizations, take up these sort of evidence-based, safe, but innovative practices extremely quickly, which I think a lot of people had wanted to do all along. So it's really an interesting to watch, how much can you demedicalize a service, which is sort of where the research about abortion has all been going over the last 10 years.
I'll just ask one more question. What can be done specifically at the policy level to help continue to support providers as they are navigating these complex issues going forward?
So many things. I think just writ large, this is not unique to this time period, but encouraging our lawmakers, both at the state and federal level, to get rid of the restrictions that are in place that are making the situation more difficult for people who are accessing care and for the providers who provide that care. There's a lot of hoops that folks have to jump through that are not medically necessary, and in a situation like this pandemic, that's just exacerbating a situation that's already very challenging. I think that Dr. Mark mentioned a couple of examples of the ways that the clinics are adapting to the situation, and the restrictions that are in place in some states that make those adaptations impossible, repealing those specific requirements, like requiring that people come in person and get counseling 24 hours before their abortion and then come back 24 hours later or 48 hours later. All of those things are just exacerbated when, picture somebody in Texas who now can no longer get care in Texas and has to travel 600 miles to another state, and they might have to go back more than once for that, or stay in a hotel, or do all of these things that are that much more difficult when we're supposed to be social distancing and staying at home. So I think getting rid of those restrictions, and then this is slightly outside of your question because it's not a policy response, but I think that the public narrative also plays a role in policy decisions and influencing lawmakers and the courts, frankly, and how they think about these things. Talking about abortion, you don't have to, I think that's a personal decision and people shouldn't have to share their own experiences, but being more open about abortion and generally, and the fact that it is essential. The public narrative should be that abortion is essential health care. And it's harder for politicians and the courts to think otherwise whenever that's the narrative.
Well, I think that's a great place for us to end. Thank you all so much for joining us today and sharing your thoughts and perspectives.